Ben.
Hello, good afternoon, good evening. Welcome to the webinar co-hosted by the European Forum of National Nursing Midwifery Associations, the European Federation of Nursing Associations, and last but not least, the WHO Euro. And we are very glad to have you here for this webinar on violence against nurses and midwives, implications for healthcare staffing. So we want to look at solutions, not only problems today, but of course, both belong to that. And this whole webinar is part of the European Nursing Midwifery Week. Yesterday, we celebrated the International Day of the Midwife. And next week, on the 12th of May, traditionally, we will celebrate the International Nurses Day. And we will, you as the participants, if you have comments or questions, so somebody raised the hand, but you shouldn't be able to do that. So it's established as a webinar, so participants only have the option to listen in. You can't talk, or if by instance you can, I will close you down. But if you have comments or questions, please use the chat or the questions and answers, both on the symbols on the bottom of your screen. And please make sure you choose your language for interpretation and use either English or Ruski on that too on the bottom. So without further ado, then we start with the program, and I invite the president of the European Forum of National Nursing Midwifery Associations, Mervi Jokinen, to give her greetings. Over to you, Mervi.
Thank you so much, Franz. And like Franz said, welcome everyone to our special webinar, which is organized part of our European Week of Nurses and Midwives across European region. So my name is Mervi Jokinen, I'm the president. And so in general, this week is a week of celebrations and events taking place across Europe. Today's webinar topic focuses on a critical and growing crisis that affects our professional daily workplace, and that's a workplace violence. Violence against nurses and midwives is not just a threat to individual safety and well-being. It has a profound and direct implications for healthcare staffing, retention, and sustainability of our healthcare systems. Now, reading professional journals and reports, it is very, very clear that the recent pandemic crisis increased the incidence of physical violence in workplace, especially in certain specialities. For example, in one of the UK reports, 90% of the nurses and the midwives reported experiencing physical violence while working. This alarming statistics highlights the critical safety issue in healthcare settings. Violence may vary. It may be physical assault to threats and with aggressive behavior. We know that the prevalence of the violence has significant consequences for healthcare professionals' mental health, feeling unsafe at work, greatly reducing job satisfaction, and resulting in nurses and midwives considering or leaving the profession. This can be identified by feeling unsupported by the employers or the system in general. Unfortunately, we must acknowledge that the threats are not all due to the external agents, patients and visitors, etc. But there can be additional pressures from internal working relationships arising from bullying, harassment, and blame culture. These high rates of violence against nurses and midwives underscore urgent need for improved safety measures and support systems within healthcare settings. Now, addressing the root of these incidents is essential to protect healthcare workers and ensure a safer working environment. So today we have brought together a variety of speakers addressing different aspects of the topic from different sources. And I truly hope you will enjoy learning more of the issues related to the topic. We all have a role in working together, keeping the conversation going and being proactive in improving our daily working environment. Every nurse, every midwife has to be valued, protected, and safe to deliver the best care they can. And I now hope that Aris, my partner and colleague, Aris Koratas, who is a president of the European Federation of Nurses, EFN, will be stepping in and saying his short welcome before we go to the continuing with the program. Are you there, Aris?
Yes, I'm here. I hope you hear me.
Yes, we do.
I'm very, very happy to be with you. Unfortunately, I have some health issues I have to deal now, so that's why I can't have the video. I'm very, very glad for being with you. And violence is a very important issue that we need to deal within Europe and globally as well. Nurses and midwives have a great problem with the violence against them, either from the public, patients, the managers. So we need to figure out ways how to help them, how to support them. And I hope this webinar today, it's going to give those inputs to each and everyone's to find solutions to the problem and find ways to prevent it as much as possible. I'm very, very happy to be with you, and thank you for hosting me. Thank you.
Thank you, Aristides, and all the best to us all. I would say happy European Nursing Midwifery Week. And now we move on to the program and invite for the first speaker. And we're really happy that you found the time slot in your busy schedule, Maggie, to be with us here today. And I invite Margrethe Leggins from WHO Europe, and she's the Nursing Midwifery Policy Advisor there, to her welcome to participants and to report on the results of the MEN study. Maggie, over to you.
Thank you very much, France and Mervi and Aris. And most importantly, thank you everyone who is joining us today for this important webinar, but also for taking time out of your busy schedules, because it's not just me that has a busy schedule, but I know each and everyone here is very busy as a nurse, as a midwife, whether you're practicing or working in policy, but also this week is particularly important, and the next 2 weeks for your associations. I also just want to say happy International or let's say European Nurses and Midwives Week. Happy International Midwifery Day to our midwives yesterday. And this will be my chance to also greet you on International Nurses Day that's coming up next week. So thank you for this opportunity to talk to you about the findings of a recent report. I don't think I have to tell a room or a virtual room full of nurses and midwives. I'm just trying to get this my way. Sorry. Nurses and midwives, just the sort of importance of this topic that we're talking about today, just sort of setting the context why this is so critical. The health and care sector is the 4th largest sector of employment, and we know it's growing in Europe. 1 in 10 paid jobs are in health and social care. And our sector is a very feminized sector. 77% of healthcare workers are women, but also our nursing profession in the region are 89%. And these women are critical to the labor force, but the health sector itself is very critical to our women, and it represents 1 in 6 of all women's employment. So there's a gender dimension to this violence that I want to talk about in a moment. Some other contexts that I think are really important is that we do tend to segregate, occupationally segregate women and concentrate women in caregiving roles where men dominate in leadership and decision-making positions. And this also impacts and is tightly linked to some of this violence that we're seeing. But also our female workers in the nursing and midwifery workforces tend to more often have part-time and contract instability that plays into the violence that plays out. We also have a gender pay gap in the health sector and even in the nursing workforce that's very female dominated, and that poverty, that paucity of funds going to our women female workers also plays into some of the violence that we see. I don't need to tell you that it harms our nurses in terms of their and midwives in terms of their mental and their physical health individually, but it also harms our systems when we don't address this issue with higher absenteeism, increased turnover, service disruption, and higher system costs. So a little bit about the report, and I should leave that on just a second more so you can scan the code. And if you haven't already read the report or engaged with the report, I think it's very important for you to look at this report. It's the first of its kind by WHO Europe. It is extremely important because, and it comes at a time when we are working with our ministries of health to support retention and recruitment, which is at the center of our framework for action, but also to strengthen the European framework for action on mental health in our region. The survey was able to be translated in 25 languages. It was limited to the EU, but we are now working to rolling it out in several other countries, including the Central Asian countries and Ukraine, Georgia, Azerbaijan, Armenia, and Moldova. But this particular report covered 120,000 doctors and nurses, and I'd really like to thank FNMA, but also EFN, who helped with the dissemination of the survey so that we could get that reach. When you see the report, you'll see that there are country profiles, so you can look at how your country did in this report, but also look at the sort of similarities and differences between nurses and doctors. Some of the key findings. Our doctors and nurses report levels of well-being that are almost 2/3 lower than that of other professions and 5 times worse than the general population. We see from this report that doctors and nurses overall have high rates of depression, anxiety, alcohol dependence, and suicidal thoughts, and that it is distinctly, the report found clearly that these mental health issues are exacerbated by violence. So depression nearly doubles with violence exposure, anxiety prevalence also is almost twice as more common amongst those who are exposed to violence. And sexual harassment has the strongest association with some mental health issues. And this pattern is consistent across all forms of violence. So whether it's patient anger, violent threats, physical violence, or bullying, all show significantly higher mental health burden amongst our health workforce. And here's just to impress that, the prevalence of mental health conditions rises, almost doubles with the exposure of violence. Here are some of the findings from the report, with managing patient and relative anger being the highest and affecting 71% of our health workers. And a third of our health workers are actually experiencing bullying and violent threats. We also know that workplace determinants of healthcare workers' mental health and well-being. We know what protects our health workers, and we know what impacts negatively their mental health. And so it is really time to act on these issues with our employers, with our associations, with our unions, to ensure that workplace support structures, work-life balance, colleague support, and autonomy and controlled are amplified, are raised, so that we can protect the mental health of our and well-being of our nurses. What are we doing in the European region? Well, the Nursing Action is working working with 21 countries, and now with the findings of the mental health report, but also quality of employment assessments that are being conducted in 21 countries, and the recent launch of the staffing capacities in countries. We launched that in February, and a dual track mentorship course that will be rolled out and launched in September in these 21 countries in 21 languages as well. We hope to really prioritize evidence-informed retention strategies for these 21 countries. But I think that these reports can be done in other countries beyond the 21 countries. And we are here as the WHO to support with the findings of the mental health report at the country level as you request it. We also, in Central Asia, just launched a set of strategic directions for nursing and midwifery, and addressing violence and working conditions is one of the 4 pillars of that work that our nursing advisors in Kazakhstan, Kyrgyzstan, Tajikistan, Uzbekistan, and Turkmenistan are working to improve. And we've been working with the ILO to start discussions in all of these countries about violence and working conditions. But we will not be able to address it only in the health sector. We need to take a broader approach and look at violence against women and girls in society. And that is why Dr. Hans Kluge has also started and launched a special initiative on violence against women and girls in our region. I just finished a policy dialogue with the ministers of health of Latvia, Lithuania, and Estonia to discuss how they plan to take forward this special initiative in their countries. And we focused a lot on the violence that's taking place amongst our health workers, so that they are, we need to care for the carers in our society, but we also need to set up the systems more generally so that our health workers can be increased in their capacity to support our patients and the communities where violence is occurring. And those go hand in hand with the response. But also, we need to look at this multi-sectorally and beyond the health sector, work with our ministries of labor, with our ministries of finance, and our ministries of education to raise this issue. What we are working on with different leaders in ministries of health is to really strengthen governance and leadership on violence against women and girls, introduce workplace systems and safety so that we protect those patients, but we also protect the health workers, and strengthening our data, monitoring, training, and prevention of violence. So I hope that it's clear from this that we have brought the scale and urgency up in our region, and we're making this a central pillar to our work, that we are working every day with our ministries to ensure safe workplaces and better care is being provided, but also that we work with our associations to reinforce that, with our hospital employers, and that we're looking at this as a wider gender responsive action, so that all WHO European frameworks integrate a gender responsive lens to them that calls for zero tolerance. So with that, I'm going to stop and give the word, I think, back to the moderator so that we can listen to some experts who can tell us more about this issue and what's being done. Thank you.
Thank you, Maggie. And it's really a kind of, it's very, I think we can feel supported that now WHO is addressing together with governments that this problem and challenges have been taken seriously. And hopefully that will really change things. And I remember quite well when 20 years ago I visited a US hospital, and in the emergency room, they had a kind of sheriff to protect stuff. I thought, this is ridiculous. This is like Wild West. And now talking to colleagues here in Europe or in Germany, it's the same situation here, that they're afraid when they go to work. We have one comment in the questions and answers. It's a very powerful report, so thank you to you, Maggie. Will the UK be included in future phases of the project? That's the question for Martin Campbell.
Well, I look forward to sharing it with the UK. We have some great advocates there with the RCN and the chief nurses of all 4 jurisdictions. So we will certainly be sharing these results with them so that they can either use the same sort of survey tool to do that assessment in the UK, but also they are very much involved in the conversations that we're having across the region. Yeah, so we're looking forward to working with the UK on this, and we know that they have expressed the importance of this issue and that they have signed on to this special initiative.
So there aren't any further questions I can see, and nothing in the chat. No. So Maggie, I know you're quite almost in a run because you have to move on. So thank you for taking the time today. Thank you for being with us. And we're looking forward to hear more about this in the future from WHO or via the newsletter or via FNMA, and to see each other. Thank you very much. Have a good day. And now we are moving on with the program, and our next speaker is from Ireland. It's Akila Rajendran. She's a PhD scholar with the Royal College of Surgeons of Ireland, and she will speak about the issue on, she will speak about, I think, a project which is going on in Ireland, but only that. So welcome, Akila. We are glad to have you with us. Over to you.
Thank you, Franz. And I'm really thankful for this opportunity to talk in this webinar with all the important personnel attending here. And I'll introduce myself. So I am Akila, and I'm representing Ireland at the moment, and I'm a nurse lecturer in Southeast Technological University in the southeast part of Ireland. And at the moment, I'm doing a PhD study on aggression and violence against healthcare professionals in Ireland. So I'll share my PowerPoint here. It's a small presentation, so it won't be too long. I'm just talking about my project, basically. I hope everyone can see this, is it?
Yes, it's working.
And excuse me for the background sound. I was traveling 6 hours to reach for attending the midwifery conference in Dundalk in Ireland. So I reached the hotel, but I couldn't check in it. I was a bit late. So it's in a silent, quiet room in the hotel, but there is quite a bit of noise in the background, which I can't do anything about it. I'm really sorry for that. So my PhD study is on aggression and bullying against healthcare professionals in Ireland. So I am halfway through my study, And I'll just go on few statistics. Oh, sorry. So, as Maggie was telling about aggression and bullying in healthcare settings, the same is happening in all the healthcare settings all over the world. There is no exception in any country. And I'm basically from India, and I moved to Ireland 20 years before. So I feel the same back in India and also in Ireland. Aggression and against healthcare workers, there is no change in any countries. It's always been there, and we have to do something to tackle that situation. And my PhD study is focusing on prevention and mitigation strategies. So it's a silent epidemic. We don't usually face it as even media try to repress it. Even if there is aggression, everyone stands at the patient side. The healthcare professionals are always facing it, but they are afraid to say about it. And there is challenges. They face significant challenges from aggression, bullying, and this can impact their well-being. Not only their well-being, but it can impact their patient care and also the retention. So we have a lot of problem in Ireland, especially from staff shortage. So in Irish healthcare settings, especially in the acute settings, there is a lot of issues going on because of the staff shortage. There is a lot of trolley patients in here, and we are trying to reduce the number of trolley patients in the emergency departments. But the staff shortage is always a problem in here. And that is leading to aggression and violence from the patients and their relatives to some extent. And I have a little bit of statistics in here from a recent study done on 30. It was done among 32 countries, among 399,000 healthcare professionals all over. So it was a systematic review. And from the systematic review, it says 75% of healthcare workers experience verbal aggression, and 82% were victims of physical violence, and also it can lead to post-traumatic. There is double chance, double chance of having post-traumatic stress disorder among these victimized staff. So I'm focusing on Irish healthcare setting at the moment. So there is a lot of studies going on in Irish healthcare setting about violence and aggression, but it is very much focused on the emergency department, or most of it is focused on the mental health department. But there is no national study done at the moment. So we are focusing on a national study which can cover all healthcare settings in Ireland, including the acute, the community, and also other settings, the OP department and everything. So there was from some of the studies, it's not national studies, but some of the small studies done by Health Service Executive, HSE. HSE is health service in Ireland, government health service in Ireland. So there was a study done by HSE in 2025, and over 12,000 incidents of violence and aggression were reported against healthcare staff. Healthcare staff means all the healthcare staff, including doctors, nurses, healthcare assistants, and everyone. So there was over 12,000 reported incidents. So this was only from a data from the incident reports, which was reported by the staff. And these reports, the problem of this incident report is that when a violence or aggression occurs against a staff, most of them will try to suppress it, or they won't say about it, or they don't want to talk about it. So only the most violent cases, or cases which caused most violent like physical aggression or verbal aggression will be reported. So these reports are very underreported. So 12,000 incidents, there will be a lot more behind the scene. And bullying. So we say aggression from patients, staff, patients, relatives, and all. But bullying among nurses has significantly increased in Ireland, especially from 2010 to 2014. And we have seen a 6% increase in the daily bullying in Irish healthcare setting. And that can be from the colleagues or from the managerial level or even from the organizational settings. So that is a significant impact for staff to leave their job or look for other settings. So we have seen a huge like emigration from Ireland with regard to nurses to Australia, Canada, and America in the last few years. So the INMO, the Irish Nurses and Midwifery Organization, had a report, a recent report in 2024 that INMO, so around 50,000 nurses are members of the INMO. So 63% of the INMO members experience workplace aggression, and 70% of them thinks reporting mechanisms deemed really insufficient, because after an incident of workplace aggression and violence, there will be incident forms written, but nothing will be done about it. So they'll feel like, what's the point in writing an incident form if there is nothing done about it, or they are not dealing with it, or no one is there to do anything or hear their voice. And consequence of staff and well-being, someone has already talked about it. There is increased stress, anxiety, burnout, and mental health issues among the staff. So this can lead to less job satisfaction and lead to absenteeism, staff turnover, and recruitment challenge. There can be people who even think about changing their profession, moving to other countries, and sometimes it can lead to a lot of absenteeism, and after all this, it can compromise the patient safety and the quality of care. So there can be problems with the organization also. So if a staff is taking sick leave, there can be absenteeism, sick leaves, and so on. It can be causing significant financial burden due to staff replacement and legal cost, which the health services has to deal with it, and also damage to organizational reputation and public trust. So my PhD study is on aggression and bullying against healthcare professionals in Ireland, and to develop an evidence-based recommendation for effective intervention and prevention of violence and aggression against healthcare professionals. So I am doing it's like a 5-stage PhD study, and I'm not only including nurses in it, I'm including doctors and pharmacists. So we'll think pharmacists can be a different profession, but doctors and nurses are the largest group in the healthcare setting, and pharmacists. I took pharmacists into my study because there is a lot of community pharmacies in Ireland, and they are facing a lot of aggression and bullying in the community setting when drug addicts and all reach the pharmacies to get their methadone and all those things, all those tablets, and they won't be patient to wait for their medications. In those cases, pharmacists are one of the key professionals who are facing aggression. So I have included nurses, doctors, and pharmacists. So this will be like a 5-stage study, and I'm starting with this. I have started with a scoping review in it in year 1. So in the scoping review, I have and at the moment it's on the run and it's nearly at the end stage, the data extraction stage, and examining evidences on pharmacists who has faced aggression. So I have explored a lot of studies, and finally came down to 17 studies at the moment for data extraction, and it will be published within the next few months. And the second stage is national survey, that's also running. So I'm doing it by hand in hand. So the national survey, it's a quantitative, it is assessing quantitative data from nurses, doctors, and pharmacists all over Ireland. So then I'll be going into in-depth interviews. So when we get responses from the national survey, we'll be doing interviews around with 15 to 20 interviews to get a qualitative insight from the people who have responded to this national survey and who are willing to take part in the interview. And our last part will be focus group discussions, because we take their experience from the staff through the survey and interviews, but we have to see what is happening with the organization. So we have to see how managers are dealing with it. We have to look into their perspectives also. So I'm having a focus. I'll be conducting 4 to 6 focus group discussions with people at the managerial level, just to see what do they think about this and what can they suggest to improve this, and about the organizational perspective also. That will be the 4th stage. The scoping review is on the go, and this will be building on the existing knowledge. There is already a systematic review done on nurses and doctors, so I'm just adding that into my scoping review. And my and the stage 2 national survey. The national survey was out on March 13th, 2026, to gather quantitative data on doctors, nurses, and pharmacists. And we have by 2nd May 2026, we have 184 nurses responded to the survey. The numbers are very low, but I'm trying my best to encourage participation. And we have 222 pharmacists responded to the survey, and 33 doctors. Doctors' numbers are very low to even represent the sample, but I'm trying to get more of the people to participate in it. So interviews, I already said, will be conducted with the participants, and now 52 people have agreed to participate in the interviews and the focus group discussions. That was a good number for that. And they'll be sharing their personal experience, which can provide rich, in-depth, qualitative insight to live realities after the survey. And after all this, I'll be synthesizing the triangulation of all these ideas from the scoping review, from the quantitative survey data, and the qualitative interviews and the focus group. All these will be merged together to get a unique idea about what is happening and what are the statistics in Ireland and what can be done about it. And we can develop a holistic and robust understanding of aggression and bullying in Irish healthcare settings from all this data. So as for solutions, from all this data, I'm planning to develop a training module. We already have a training module in Ireland, like a CPD module, which helps staff to staff to react against aggression, and also some of the physical strategies they can use to react against aggression. But some of these modules are not very comprehensive, because even with the modules, still aggression is happening. Still, staff can't do anything about it. So I think there has to be some modules which has to be added into these CPD courses. And I found like effective communication and de-escalation techniques for frontline staff. That was a major thing I found in many of the studies when I was doing the systematic review, that they are not trained on communication skills. I think by training people on communication skills and how to deal with it, and how to talk when an aggressive incident is happening, or when a patient is getting agitated, that has to be included in that CPD modules. And also, after doing all these survey, interview, and all, I think I'll get more aspect to include, and all more details which I can use to include in these modules, and improve the CPD module a little bit more better, so that it might work for the staff a little bit. So building a safer healthcare environment, that is my wish. The proposed staff training module, informed by this comprehensive research, aims to equip healthcare professionals with skills and knowledge to prevent, manage, and also recover from aggression and bullying. So hopefully it works, and hopefully we'll get more representative sample from Ireland. Thank you.
Thank you, Akila, for this presentation, and good luck with continuing your study and your
Thanks.
research. I think it's really a big task which is ahead of you. And as you mentioned that the participation rate is rather low,
Yeah.
in particular considering the total number of nurses with the nurses. And I found in the literature quite often that it is assumed that there's a lot of underreporting of violent events nurses and midwives and others experience. So do you think this is somehow related that people are reluctant to talk about it? Or do they take it for it's part of the job? You can't do anything
Um,
about it?
I'm trying to send it to all it is underreporting can be a little bit because my recruitment strategies were a little bit halted in the after the survey was published because I had few organizations which agreed to recruit it, send it through the staff emails, but they backed off in the end because they were getting lot of requests from lot of researchers, so they couldn't
I see.
just help one researcher in here. So there was a little bit of halt from that side, but I was publishing my survey through a lot of social medias and all to get more reach, but that can be a little bit reason for the underreporting and non-participation, obviously. But I'm still going, I'm attending a nurses and midwives conference tomorrow, so try to see if it will
Yeah,
boost up a
yeah.
little bit.
Good luck with that. But again, so do you agree that, or is it? Do you share this idea? There is a lot of underreporting. So
Of
the
course,
numbers are terrible as they are. So
yeah,
the ones we know about, if there is a big
there is.
hidden,
Of course, I agree to that because a lot of underreporting is happening. Even I work part time as a nurse in frontline also when I'm lecturing in the college. So I like even when I'm working in the frontline, I feel a lot of my staff facing all this aggression and also bullying from the higher up from there where they are. But they try to because if they try to report a bullying from their colleague or their manager, they'll be scrutinized or they'll be the target for their next aggression.
oh,
So they'll try to oppress it and just silently have it all. And in the end, they'll think, oh, I'll just move out. So we have a lot of emigration to Australia for the last 10 years. And it is nothing is done about it. And a lot of the nursing students in the
yeah,
college also, where I am teaching at the moment, everyone's ambition is take 1 year experience in Ireland and move to Australia. So
yeah.
that should be addressed obviously, but needs more studies has to be done on it.
Yeah, so experience violence might be a push factor
Of
for
course, yeah, it is.
not only leaving the profession, but a step ahead,
Yeah,
moving to a different country. So thank you again, Akila, and
thank you.
I hope we will have time at the end of the webinar for more questions. Currently, there is none, neither in the chat nor in question and answers, but I'm sure we will, in a discussion we'll have at the end,
Yeah,
and then I'll ask you to
thanks.
join in. So thanks again. So we are moving on from the very west of Europe to the very east, not the really, but to the east, far to the east of the European region of WHO, to Kazakhstan. And I'm really glad that we have here Ainagul Noruzbajeva. Please, my apologies for butchering your name. She's the Chief Nursing Officer of the Republic of Kazakhstan, and she will speak to us about the situation in Kazakhstan. And I'm going to share her presentation, and she will tell me when to switch. So,
Включиться.
Ainagul, it's your turn now. Oh, she's not here.
Yes, Franz, I don't see her.
Yeah, I can't see her. Maybe we lost her.
I don't see Aina Gul among the speakers. Probably there was
She
some
disappeared. She was
internet.
here a minute ago. So then we hope she will. We hope she will be back later on. So we would move on to Anita Prelic. She is the president of the Slovenian Nurses Association and treasurer of EFN. And we are looking forward to your presentation. Please, Anita, it's your turn.
Thank you very much for a kind invitation. I will start with my presentation. At least. Is everything okay?
Yes, yeah, it's okay.
Yes. So, dear colleagues all over Europe, I will talk today a little bit about our pathway to tackling violence in healthcare settings in Slovenia. What kind of actions we already done in the past, and for introduction, for the start. I want to share some information with regulation, Association of Nurses and Midwives, We recognize that the field of prevention of violence is well regulated in Slovenia, particularly in the area of labor law. However, I have to say that healthcare legislation is somehow less well regulated, but still better than in other healthcare systems all over the globe, which some information I already have from the past. So this topic, violence, prevention of violence, the escalation methods, are part of the mandatory curriculum that all the healthcare professionals must cover to renew their license. In Slovenia, is this every 7 years, and is the same for doctors, nurses, and midwives. So all these topics are somehow included as mandatory. And in last 20, 30 years, we somehow made a good good collaboration with many different organizations, good cross-sectoral cooperation with the Ministry of Labor, like I already said. Then also with the Ministry of Interior, other professional association, doctors association, physiotherapy chamber. And of course, we always include non-governmental association, which are crucial in our cooperation over the past 25 years, because 25 years ago, we started working group of non-violence in nursing and midwifery, established inside the association. And here is the link to video which we prepared last year when we started, when this big anniversary was on the end of the year. And this working group is multi-professional. There are a lot of nurses, midwives inside, but also anthropologists, sociologists. So we are together preparing different national protocols, like for elderly people, violence against women in family or children, cyberbullying, sexual violence. So many different protocols are available for all health professionals in Slovenia. In 2022, we also published publication, No Violence. It is in English because in 2022, there was a first EFN conference after the COVID time, and we want to prepare something special. So this book, Handbook for Dealing with Violence in Health and Social Protection Institution, is available also for you. I can share QR code, so it's for free. A few months ago, in December, we also prepared some recommendations for preventing violence against community nurses in Slovenia, because we are facing such a lot of problems with communities where actually healthcare nurses are alone, stepping into the home, rural environment. So they are in some, they're unprotected. There are some, family members, dogs, different areas. So many problems in their service. So as an association, we also somehow serving with individual counseling and mediation when there is something happen in the hospitals or in the healthcare centers. So if there are any problems, we need support service, and as an association we support this, pay this additional support to different healthcare professionals, not only for nurses, but usually nurses are included. In last 25 years, we produced three national researches, and all of there were preparing under the working group of the non-violence. And what we recognized from these three studies, that violence is caused by third parties. These are patients, relatives, family members, and this kind of violence is increasing each year. So almost every nurse faced with any type of violence in their practice. This is the last result from our research in 2025. So the working group for nonviolence in nursing and midwifery produced many activities, so that also for employers, for the management, with clear guidelines, protocols, so they know what to do if they're in such a situation. I have to say that according to our evidence, we made some steps, some recommendations for the healthcare service, also social service. So such a panic button, management protocols, like I already said, and we also training person as a designated personnel, and they help directly. Each association, each health care service or hospitals have to have a designated person, which is helping nurses and midwives and other people working in this environment. If something happen, they know who is this person, and they and usually they help them. So I have to say that we are one of the, in my opinion or my knowledge, one of the association which also mention violence in our codes. We have own code of ethics for nurses and also a new code of ethics for midwives published last year. And we also know that as a health professionals, we also somehow can contribute to violence against patients. So we mention somehow self-reflection in our code of ethics as contribution to a better service for people. So in a very short presentation, I want to end with one of the information for you. Most of you already know the new European projects, Brave Wolf, which is building respectful and violence-free, gender-inclusive environments in the world of work is as the key goal of these projects. And 14 partners from Portugal, Italy, Slovenia, Spain address the gender-based violence and harassment in their workplace. And we are part of these projects, and very happy that somehow the projects is in the progress. We work together with Slovenian Ministry of Health and University Medical Center of Maribor, preparing the questionnaire and the next phase of the projects. And for the end, many of you were already in Slovenia. For those they are not have opportunity yet to come, I know that Maggie is coming in September, I hope. Bled and Ljubljana is always welcome you. Mary and Franz was here already, so greetings from Slovenian nurses and midwives. I wish you all the best all over the Europe.
Thank you very much, Anita, and I can confirm that Slovenia is a beautiful country and very nice people there as well. Not only Anita, everybody there is very nice. So thank you for sharing that with us. And you told us that you're dealing with this challenge for quite a long time. And but would your general estimation be that you made progress, or is it an uphill battle with a situation where you feel the forces against it are stronger than what you can do to solve or minimize the problem?
So I think that our steps in the past are going in were good, and we are now on the good pathway. Like I said, 25 years ago we start to talk about violence against nurses and other health professionals, and we are actually one of the first. We are the first professional group in health service which pointed out this problem. So somehow, like I said, we cooperate with many different stakeholders, and I think that it's very important that we made the health service, which is under other pressures in last years, safe also for the nurses and midwives.
Okay, thank you. And I hope you can stay around for the final
Yes,
discussion in the end of
no
that.
problem.
So
Thank you very
now,
much.
thank you again, Anita. Then now our colleague from Kazakhstan is back, and she's going to share her presentation with us. And I invite everybody who hasn't done that yet, because this presentation is going to be in the Russian, to choose in the interpretation button or translation button, English or Russian, whatever language you use. So it's on the bottom. There is a button for interpretation to choose the language. So now we move on, and we are glad that she's back, to Ainagul Narazbayeva from Kazakhstan. As I said, she's the Chief Nursing Officer of the Republic of Kazakhstan, and we are glad. Now she's gone again. Oh dear. Apparently, it's every time I say her name, she loses the connection. I think we'll give her a minute or two if she's able to reconnect. So Anita, bridging the time until hopefully she's. So we are.
I'm here.
We are the entertainment now until Ainagul is back. Is there any legislation from your government to give a special protection to healthcare professionals if they experience violence in Slovenia?
Sorry, I didn't hear the question.
Yeah, so is there a law that says if you hurt a nurse, you get a more severe punishment than you hit your neighbor or somebody else? So is it more punishable if you behave violently towards a healthcare professional?
Of course. I have to say that, for example, a medical chamber wants to somehow put in the regulation that in the law that this is a criminal act if,
Yes.
for example, if patient is, aggressive or use some, gun or knife or whatever. But this was not implemented. We don't want such a, patients are under the pressure too, of course, and nurses and midwives also, but there are different ways to come down. Some, like I said, the knowledge about the escalation methods, about the violence, how to protect ourselves in such a situation is mandatory in 7 years period. So I think this is one part of the our work, and I think it's for enough. It's good.
Yeah, because here in Germany, so we have been kind of arguing with the government for many years that it should be more severe event if you hurt a fireman or a nurse or a doctor or an ER person. And they always said, oh, that's difficult. And so, but a few years ago, legislation has changed. So now if you really hurt a nurse, let's say, or a doctor, you may have a longer sentence in jail. So if it's really a severe case, then if you hit somebody on the road, you don't know. So it's that's quite difficult. But we are not sure if that really makes a difference in preventing these events, because most likely most of the time people really don't think and say, oh no, I won't now affront this nurse because I might get more severe punishment. They are in a kind of state of mind that doesn't allow them. So there's still no Einagul, so I wonder if we should move on. Natalia, do you have any recommendation? I'm asking our interpreter. She will have more experience.
Franz, unfortunately, I can't tell you anything. I don't see. Oh,
Okay.
she's back. She's back.
Ah, she's back. Okay.
No,
Okay.
yes,
So
yes,
thank you,
she's
Anita.
back.
Bye.
Hi, Ainagul. Good to see you. And we now immediately start. So I announce you 3 times now. Ainagul Narusbajeva, Chief Nursing Officer.
Excuse me.
Sorry?
She started to speak.
Okay. And I start the presentation.
Okay.
Here we go.
Здравствуйте, уважаемые коллеги.
Good afternoon, distinguished colleagues, dear colleagues. I'm happy to say hello to you.
Now she's gone again. No, here she is.
Я прошу прощения, почему-то у меня
I'm
выбивает
sorry,
интернет.
unfortunately, my internet connection is so weak, but I want to share with you.
Мгм.
Maybe if she switches off her video, it might be more stable.
Уважаемые коллеги,
stop
разрешите
video.
поприветствовать всех
Dear
участников.
colleagues, let me say hello to all of you. It stopped.
Natalia, can you hear me?
Yes.
If she closes her video, there might be a more stable connection if she only speaks, because I have the presentation and we can hear her voice. If you tell her that, please.
Franz, I'm not sure that she can hear me.
Yeah, it appears
She's
the picture
frozen.
is frozen. Yeah, now she
Yes.
disappeared. Let's give her a second, otherwise we just have to leave it out and ask her to do a recording of it later
Yes,
on.
probably.
And then we can put that on the edit to the thing. Mervi, yes.
Yes,
Mervi, you raised your hand.
Yeah. I just thought that it might be quite possible that we could record it and we could add into the recording of the whole webinar. So we'll go straight forward we can have that discussion with
she's
her
back
later.
again.
Yeah.
So I give her a last try. She's back, and so Natalia, so we give it a try. She should switch off her video, and then if it works, we do it. Otherwise, we simply won't do it today.
Хорошо.
Okay, давай.
Всё, я поняла. Мгм. Начинаю. Здравствуйте, уважаемые коллеги.
Once again, distinguished colleagues, I'm happy to welcome you and to thank the organizers for the invitation and the opportunity to speak about violence towards nurses and midwives. I'm going to tell you about our comprehensive system of protecting medical workers in Kazakhstan. In our republic, in accordance with the order of the head of the state, the Ministry of Health decided to implement a comprehensive policy on legal and social protection of healthcare workers. It happened because of a huge amount of aggression and violence our healthcare workers faced in the recent years. We witnessed high-profile attacks on medical workers in some regions and cities of our country. And as a result of these attacks, healthcare workers got severe traumas, injuries, and even lost their lives. Unfortunately, it's true that people who devote themselves to healthcare provision face threats, insults, and physical violence, and we can't wait but decide and overcome this issue. We need to go to slide 2, Franz. You're too fast. So a special law has been implemented in our republic in an answer to more than 180 attacks towards healthcare workers. And there were just in last year 65 cases of attacks against medical workers, most of them from doctors, nurses, felshers, and ambulance drivers. The law and legislation existed last year and before the last year were not enough to stop the aggressors, and it was not enough to punish them, and it was not enough to explain to the society that it's not just a domestic conflict, it's a threat to the whole healthcare system, not a threat to an individual healthcare worker. So our members of the parliament of Majlis in Republic of Kazakhstan came together to a decision and supported the order of the head of state, which requested stronger liability and responsibility of aggressors against our healthcare workers. Next slide, please. So a new article was added to the Criminal Code of Kazakhstan Republic, and the code from now on establishes higher fines and higher punishment towards aggression, for aggression against healthcare workers. You can see the level of fines for the threats, verbal threats, which goes up to 4,000 euros, or some public work and public services, or even imprisonment and restriction up to 2 years. And if violence occurred, then the person will have a stronger punishment. Here, they might be, it might lead to a fine of 4,000 to 8,000 euros, or 6 hours of public services without payment, and imprisonment up to 3 years. If it was a more severe aggravated circumstances, then restriction or imprisonment may take up to 7 years. If an act of violence is dangerous to life and health of the healthcare worker, then imprisonment goes up to 10 and even 12 years. The same law allowed police to conduct a preliminary investigation and inquiry at the place of violence, just at a moment of violence. And the criminal code protects not only healthcare workers, but also ambulance drivers and other healthcare workers that are engaged into provision of healthcare services. And the task of this law has a dual task. It also, another part of this law creates a shift from punitive control model to a model of systematic improvements. And the state takes on responsibility to protect healthcare workers and to provide the possibility of the healthcare system to function. And nowadays, an institute of professional liability is introduced. Yes, thank you, Franz. And there is a strict distribution on legislative level of medical error, negligence, and intent, which protects healthcare workers from unjustified prosecution. Next slide, please. We took international experience from Great Britain, Canada, and other countries, and we provide our healthcare workers of how to de-escalate the conflict, how to behave, to make it easy for the case. We also were teaching our healthcare settings and administrators, and we work on alarm buttons and inviting and recruiting security staff. So, taking into account the growing risks and threats, we are trying to strengthen our healthcare facilities as much more protected. And the law on strengthened punishment towards aggression will strengthen all these efforts. We understand that it's impossible to protect a medical worker without increasing its status. Next slide, please. And our laws today attract healthcare workers to rural areas with extra money, allowances, and these are quite big money, more than 15,000 euros per specialists, which are in special shortage, in deficit. Rural doctors and nurses may participate in international conferences and training programs. They also receive specific grants to improve their qualification. We also trying to grow internal services of patient support and of healthcare professional support. And these services exist on the basis of each healthcare facility to protect rights of both patients and nurses. So the whole purpose of our efforts is to provide healthcare as a place for safety for all, and we are sure that only feeling safe, healthcare workers can provide safe and quality care. Also, as we already talked about reporting the cases, in Kazakhstan, we are trying to implement an electronic register to implement any medical incidents. And in conclusion, I want to add that it will be a comprehensive program to protect all doctors, nurses, midwives, pharmacists, felchers, and the whole law will protect every citizen and every healthcare workers. I want to thank the organizers of this webinar and want to give you best congratulations to midwives with International Midwives Day and to send our greetings for the International Nurses Day. And I wish you all a strong health and well-being. Thank you.
Spasiba, Ainagul. So, and thank you very much. We are really happy that you were able to give us your presentation, even there were some hurdles. So that is really good that we did manage this. And I have one question in the question and answers. Does the law only apply to violence while at work, or does it cover violence that occurs while, oh, can't read that. While going to work and leaving work. So if it does it only apply if you're on the workplace having started your shift, or if you walked or drive your car towards the work, if you experience violence, then would the new law apply as well?
Закон предусматривает
The law
насилие на медицинского работника вне
says
зависимости при
about
исполнении
violence towards healthcare worker, and it doesn't distinguish the time of healthcare shift or not. So it's
вообще у нас он идет при исполнении служебных обязанностей. Но здесь нужно, да, наверное.
Well, it's a serious question. Unfortunately, I can't answer it. It's an interesting question. I think in every case, it would be some investigation if this person is already in the process of providing her duties.
Yes,
when on the way to her work.
Yeah. Okay, I don't see any other questions. So thank you, Ainagul, and it is. No, I thought it was a question, but it's a thank you from Murray in the chat. So, and I encourage participants, if you have any comments or questions, please use the question and answers or the chat to bring forward those questions or comments you have. And so we move on to our last speaker for today, which is Valentina Tomasi. She's a university professor in Milan, and she will speak on the topic from an Italian perspective. So, Valentina, the floor is yours.
Thank you. Can you see my screen?
Not yet. We can see you.
Okay. So, okay. Now, can you see?
Here we are. You only need to move to presentation mode. Yeah.
Okay.
Excellent.
So thank you and good afternoon, everyone. I'm very grateful to be here today, and I would like to thank you, Walter De Caro, the president of CNAI, that is the Italian National Association of Nurses. I'm very grateful for this opportunity. So I work as an educational nurse at the University of Milan, and I am a member of CNAI. So today I have the privilege and also the responsibility of sharing with you the Italian perspective on one of the most urgent challenges facing our profession and our healthcare system, the violence against healthcare workers. Violence against healthcare workers is not an Italian problem, nor an European problem. It is a global emergency. The World Health Organization, the International Labour Organization, and the International Council of Nurses have all recognized it as such. It affects facilities and personnel worldwide, across all settings, all specialties, and all levels of care. In Italy, reports from our National Observatory on the Safety of Healthcare Professionals, from professional orders, and from trade unions all converge on the same conclusion. This is a serious, growing, and deeply concerning phenomenon. The scope of violence is broad. It includes aggression from patients and their families, interprofessional conflict, and outright attacks on healthcare facilities. What makes the Italian situation particularly alarming is the scale of underreporting. The FNOPI, our National Federation of Nursing Orders, estimate approximately 125,000 aggressions in a given year, yet only about 5,000 were officially recorded. Think about that for a moment. We are capturing barely the 4% of reality. Now, when we look more closely at who is affected, a clear pattern emerges. Violence in healthcare is profoundly gendered. Women constitute between 60 and 75% of all victims. This is not coincidental. It reflects both the demographic composition of the healthcare workforce and, unfortunately, broader societal patterns of gendered violence. Regional data from 2024 and 2025 confirm this disparity starkly. In Lazio, the region that includes Rome, 1,840 aggressions were reported, with 68% of victims being women. In Emilia-Romagna, one of the largest northern region, 2,700 aggressions were recorded, and 73% of victims were women. These are not isolated findings, they are consistent across the country. In terms of professional categories, over 55% of all victims are nurses. This is followed by doctors at 17.3% and the OSS, our healthcare assistant, at 9.5%. In Italy, the primary settings are hospitals, and within hospitals, the most dangerous area are the emergency rooms, SPDC, our psychiatric diagnosis and treatment services, and general inpatient wards. We are also seeing increasing reports from correctional healthcare facilities, which present unique challenges in terms of security and staff protection. The predominant aggressors are patients themselves and their families, members, or caregivers. This is important because it shapes how we must respond. These are not random criminals entering our facilities. They are often people who are themselves in distress, frightened, confused, or frustrated by long waits and perceived inadequate cares. This does not justify violence in any way, but it does inform our prevention strategies. As for the nature of violence, 70% is verbal, 24% is physical, and 6% involves property damage. Verbal violence, while often dismissed as less serious, has profound psychological consequences and frequently escalates to physical aggression if left unaddressed. One of Italy's most critical challenges is the culture of underreporting. One problem is normalization. Violence has become so common in certain settings that it is perceived as an unavoidable part of the job, something you simply endure. Some professionals even confuse aggressive behavior with patient distress. The second major barrier is the perception of futility. Many professionals genuinely believe that reporting an incident will lead nowhere, that nothing will change. And unfortunately, past experience has often confirmed this belief. creating a self-reinforcing cycle of silence. There are deeper, more insidious barriers as well. Fear of repercussion and victim blaming is widespread. Professionals worry that reporting will negatively affect their career. Superiors will question their competence, or that colleagues will perceive them as weak. Complex reporting procedures represent another obstacle. Forms that are difficult to find, complicated to fill out, or that require details the professional may not remember clearly in the aftermath of a traumatic event. And finally, there is the desire to forget. Selective forgetting or active repression of the event serves as a coping mechanism. But from a clinical psychological perspective, this avoidance behavior is actually a hallmark of post-traumatic stress. The economic impact of violence in Italian healthcare is staggering and growing. Materials damage amounted to 30 million in 2017 and 12 million in 2014, a 150% increase in 3 years. Personal injury cost includes lost work days. Every day a nurse or doctor is absent due to an aggression-related injury is a day that the remaining staff must compensate, increasing their own workload and vulnerability. Prevention costs are also substantial, like environment renovation to make spaces safe or installation of alert systems and panic buttons. All necessary investment, but investment that drain resources from direct patient care. Beyond the measurable economic costs, there are hidden costs that may be even more devastating in the long term. First, reduced quality of care. When healthcare workers operate in an atmosphere of fear and tension, their clinical performance suffers. Second, the workforce exodus. Professionals are leaving the field, not retiring, but actively choosing to abandon healthcare career. In our country that already faces a shortage of approximately 65,000 nurses, this hemorrhage of experienced professionals is catastrophic. Third, the psychological toll. Increased stress, chronic anxiety, burnout syndrome, depression, and in severe cases, full post-traumatic stress disorder. Italy has not been passive in the face of this crisis. Our legal and institutional framework has evolved significantly, particularly in recent years. The Law 113 of 2020 addressed the safety of healthcare professionals, mandated the development of operational protocols in collaboration with law enforcement, and introduced administrative sanctions. Alongside these structural measures, there has been a growing emphasis on creating a reporting culture. An annual National Awareness Day, March 12, was established to keep this issue in the public consciousness. On the criminal law side, the Italian Penal Code was updated significantly. The Article 583, quater, now includes aggravating circumstances specifically for violences committed against healthcare professionals in the exercise of their duties. Penalties have been increased, and crucially, these offences are now prosecuted ex officio. This means the state proceeds with the prosecution even without a formal complaint from the victim. The Article 635 was also amended to address property damage to healthcare facilities specifically, with increased penalties and mandatory arrest in flagrante delicto, meaning that in an aggressor is caught in the act of destroying hospital property, arrest is no longer discretionary but mandatory. Most recently, the Law 171 of 2024 introduced mandatory arrest in flagrante delicto for assault, not just property damage, and includes provision for deferred arrest. Ministry and regional guidelines complement these legislative frameworks by detailing reporting procedures, available support mechanisms, and operational standards. Italy is moving toward a more comprehensive and enforceable system of protection, but legislation alone does not change culture, and enforcement remains inconsistent across regions. Effective prevention requires a multi-layer systemic approach. Training is fundamental. Staff must be equipped by practical skills, therapeutic communication technique, early recognition of escalation signals, conflict de-escalation strategies, and comprehensive risk assessment and management. This training must be ongoing, scenario-based, and integrated into professional development at every level, including university at the university settings. Environmental improvement can significantly reduce the risk of violence. Comfortable and well-designed waiting areas reduce frustration. The use of media and entertainment as distraction in waiting rooms helps manage perceived wait times. New construction and renovation should be evaluated proactively to reduce potential risk factors. Reporting and documentation must be simplified and made accessible to healthcare professionals. We need dedicated incident reporting registries with streamlined procedures, ideally digital, accessible from any workstation, requiring minimal time to complete. Psychological support must be readily available. This includes immediate access to mental health services after an incident, structured debriefing sessions, and ongoing legal and administrative support for victims who choose to pursue formal complaints. And finally, security measures must be concrete and visible, like trained security personnel present in high-risk area, or a functioning alert system and panic button. The goal is not to turn hospital into fortress, but to ensure that help is always accessible when needed. I want to take a moment to discuss a document that remains fundamental to Italy's approach. Ministry Recommendation number 8, issued in 2007. Nearly 20 years old, it was remarkably forward-thinking. It promotes awareness and encourages a reporting culture, aiming to foster greater understanding of violence as a systemic risk rather than an individual failure. It identifies risk factors, pinpointing high-risk areas and high-risk patients group. It recommends implementing a zero-tolerance policy with the creation of dedicated working groups for analysis and prevention within each healthcare organization. And it emphasizes staff training and support as fundamental pillars of any prevention strategy. This recommendation has been influential, but it remained exactly that, a recommendation. This is precisely why CNAI, together with our scientific society and partners, is advocated for concrete legislative action. We have put forward 3 key proposals. First, elevate Ministry Recommendation number 8 from a non-binding guideline to actual law. Second, formally integrate violence prevention into existing workplace safety regulation. Violence must be treated as an occupational hazard, just like chemical exposure or ergonomic risk. And third, we have developed specific proposals addressing structural and technological upgrades to facilities, organizational measures, comprehensive victim support programs, and a stronger, more formalized interface with law enforcement. I want to leave you with one core message. Protecting healthcare workers is not a luxury. It is not optional, and it is not secondary to patient care. It is a prerequisite for quality patient care. Italy has made significant legislative progress, and we should acknowledge that. But legislation without implementation is merely words on paper. The challenges that persist require sustained commitment, cultural change, and continued advocacy from professional organizations like CNAI and from international associations and the World Health Organization. What gives me hope is the fact that we are talking across borders, sharing experience, and recognize that it is not someone else's problem. It is our collective problem, and it demands our collective response. We must move forward together because a safe healthcare system is a better healthcare system. So thank you very much for the attention.
Thank you very much, Valentina. Mille grazie. And it's and I really particularly liked what you said towards the end of your presentation, that it is a right to be protected, that it's not something you should need to fight for, but you're entitled to it, to be protected, to feel safe at your workplace, and that we all together as a society need to move towards that. And it's quite impressive what in Italian has been happening so far with all the legal protection. I think I haven't seen anywhere such a detailed approach to that. So that's really a very good thing. What we need to change now is what's in the heads of the nurses and the midwives and the doctors and everybody else, to make sure they make use of that and not are ashamed or take it as part of the job you can't change anyway. So thank you very much for that. Before we start the general discussion here, just some information for our participants. So if you have a comment or question, please use the chat or question and answers. And the recording of today's webinar will be made available on the YouTube channel of EFNMA, EFNNMA, where you also can find previous webinars we had on different issues like prescribing by nurses and midwives and other things, or artificial intelligence. So now I invite all the speakers of today, including Mervi and Ari, to join us here in the panel, and just to start the discussion, and hopefully some of the participants will join in this discussion. So after having heard the different presentations from across the continent, and unfortunately we have lost Ainagul, and Akila had to leave too, and as did earlier Maggie, but with all us here, so we see it's a complex issue. It's a long-standing challenge. So many years ago, I found a documentation with a training manual produced by WHO, ICN, ILO, and IPS in 2025. So more than 20 years ago, they made a publication. So there was awareness that there is a challenge here already then. And now 20 years moved on, we still need those manual serious appears. So if you had to choose one strategy for where you think that would have the quickest effect to reduce the challenge here, what would that be? Do we have any options here? Any opinions? Any favorites? Or is it that as a complex situation, it needs complex answers only? Yeah, Mary, go ahead, please.
Okay, I think the complexity is quite evident from all the presenters. I think we all had the background and the evidence and the information what is happening, but part of this may be like everything that is addressed with sort of near misses and incidents in the hospital. It's about human behavior, isn't it? I mean, I was extremely interested that maybe we can expand a little bit on what Anita was saying about the new project Bravo, Wow, or Wow, whatever you pronounce it, because I think some of the speakers sort of touched on the base that it's quite a lot of linked into gender violence. And I think sometimes if you look at the numbers on the female gender, that they are on receiving end of the violence either in the workplace or bullying and harassment, and especially sexual harassment with the other employees. There's this is the difficulty in the balance because even within their everyday life, they are the ones that are victims outside their workplace. And it means that they have learned behavior at being quiet. And if we have such a large amount of female workers, not majority, because I would never say that that would be that would be patronizing. But if there's a learned behavior that you don't have such a loud voice, as we know in many of the global countries that I have come across when we discuss this, and I think in European region too, it's a difficult one. Do we start and address it with the legislation and go heavy? Do we have those, like Valentina said, you can have recommendations, everything, even your workplace health and safety covers you for equipment safety and etc. You can be prosecuted and find a lot of money. Or is it that we have to talk to the public and the society and the community and start to get the campaigns and the messaging collectively from our organization saying, A, we do not condone we are for zero tolerance. We don't condone any violence towards the healthcare workers. And same time, start to say, if you do come across that, even from healthcare workers to a patient, you have a voice. You need to voice because by your voice, you stop it to a point because it'll be addressed hopefully. And if the ball starts rolling and we can stop it. That's my big dream. Now, individual ones, I'm sure you can do other things too.
Anybody else wants to come in on that?
I agree. I agree with Mary. I think that the culture, the minds of healthcare workers need to change because usually the change in legislation and the laws arrived after a cultural change. So it's really important to start to think about what it is violence, because also the verbal violence sometimes is not considered violence, and is important to start to protect people that decide to speak loud. So health workers that decide to speak in favor of the not violence against health workers. So I think that we need to implement our culture inside the healthcare workers, doctors, medicals, nurses, and others professionals.
Yeah, I think that's, and you would assume that employers are more interested in the light what Aquila said, that nurses and midwives and other healthcare professionals may decide to leave the profession or to at least move to another country where they feel better, better treated or less threatened, maybe, so that in a time of shortages in all the healthcare professions, that employers would be interested to create an environment that's positive, and among that, not violent, and protect people, their employees, from that violence. Valentina, you addressed another issue about the definition of violence, and I think it was interesting to see what we've heard from Kazakhstan, that the law differentiates between verbal violence and then two levels of physical violence. So life-threatening or not life-threatening, which is a kind of wow, if you think about it. But
Yeah.
still, I think that's another issue, and I think that still applies to research as well. That it's quite difficult to get really exact numbers because people might use different definitions, and that's the same in the workplace, and that might vary individually. That somebody says, "Oh, come on, you're too sensitive." It was a
Yeah.
joke. It was a joke. No damage done.
Yes, and it's also, I think, a gender problem because a lot of people are women, and so it's different if a woman says something or a man says something.
Yeah.
So also the consideration of pain, or what is it violence, and I can leave this kind of difference also from my students. That think about in different way if they are men or women.
Yeah.
I think that I had another webinar I attended, and it was very interesting actually how under the surface sexual harassment at work can be, and how many people have actually been on the receiving end of it. So that it's very culture in that unit or that trust happened to be, or that ward happened to be on that way. And it wasn't picked up because nobody said, they thought, oh, he's just joking, it's just banter, I need to accept this. If I say something, they think I'm being, just like you said, Franz, too sensitive. But the other thing that I picked up, those shocking figures from Central Asia, is regarding actually being killed, that losing life in your job. And I'm wondering, because I was sort of thinking back, having practicing in UK, that we do sometimes have in the media saying ambulance, paramedics or somebody died because of the violence. But the numbers don't hit such a large number, and everybody goes up in the arms, but it isn't in such a large numbers that other countries it can occur. So I think it's something statistics of those and the economic about the money that we are constantly saying isn't there for medicines and equipment and etc. that you mentioned, in Valentina, in your presentation, of actually how much is lost on equipment and everything. These are areas that are not necessarily always on the front. It's easy to say about the common issues about violence, somebody actually attacked me, but not that are everything, the full picture. And that's why it was really good, because it was presenting all angles.
So I'm just learning that I'm able to allow participants to speak. But as I saw, Anita, you reacting to something Mervi said, you go first, and then I will allow Karen to speak if the technology works. It's my first year, so we'll see.
Just short information, like Mary said, I agreed that legislation and protocols, everything is very important to prevent violence in the healthcare service. I just want to share one information which I heard maybe 2 or 3 weeks ago. Why are people so impatient? Wherever you go, or this is the gas station, hospital, community service, blah, blah, blah. And one of the anthropologists said that this is because we live in the modern society where every information is available in the second, you know. You just type in Google, I don't know, about this, about that, and information is on the hand in less than 30 seconds. But when you're waiting in the, you know, in the health service for the doctor, for the procedure, for the, maybe you already wait 1 week or I don't know, many 1 years for one specialist appointment, and nothing's happened. You are sitting there waiting, blah, blah, blah. And people which in everyday life got information in immediately, they are in panic, you know, what's happened, blah blah blah, and so they start with aggression. So I just want to share this thinking from other views, patient view.
Thank you, Anita. So welcome, Karen. Karen Bureau is the Vice President of EFNMA. So if you unmute, yeah, here you go.
There you go. Thank you very much, Franz, and it's nice to be here with everyone. I just wanted to bring up the MEND study, the mental health in nurses and doctors that was conducted by the World Health Organization in the European region with funding from the EU. It involved 29 countries in the EU.
Karen, sorry if I interrupt, but Maggie Langens presented the findings of the study.
Well, thank you very much. But I think it's really important to remember that 50%, over 50% of those who participated in that study experienced violence and harassment. And so the mental health repercussions of being exposed to violence is really a serious issue. Not just for healthcare in general, but for the individuals who are engaged and who suffer from violence. Thank you.
Thank you, Karen, about that. So here from the panel, anybody else wants an address? One of the things we have heard today, a lot of food of thought, forethought, not of thought. I got a feeling we have a very comprehensive panorama today on what are the reasons, what's the phenomenon, so how do people experience it, how do they react or non-react. And I think the for me takeaway lesson really is that legal punishment is one thing, and it's a kind of a recognition by society that there is a problem and that healthcare professionals need protection. But it's the mindset of us, of ourselves, of the healthcare professionals, that we need to change, to be more alert for ourselves, not to accept violence as a part of the job issue, and that we need to look out for our colleagues as well. So to make sure if we experience something that looks like that, we are protective in the situation, but even afterwards to be supportive, to help them. And it's really what Valentina said about kind of putting it in mentally in a place where you don't think about it anymore. There could be PTSD, a kind of PTSD that you're experiencing. And I think that's really something we cannot allow in our work environments. So this has been today a very heavy topic, but hopefully with quite a range of improvements, potential improvements as well. So because that was our focus, implication for healthcare staffing. So we wanted really to look at what can be done. How can we improve the situation for our colleagues and for ourselves? So as I said, a heavy topic for a celebratory week, the European Nurses and Midwives Week, but still. So I hope everybody of you can take something with you as a part to become part of the solution at your workplace, being helpful for your colleagues, and maybe be better prepared yourselves in case you experience violence yourselves. So happy European Nurses and Midwifery Week. Thank you, everybody who presented today, for your contribution. It was, again, I think, a very interesting webinar, and you can look forward to the next one. We will announce dates and topics via social media. And as mentioned before, all the webinars are being recorded and available through the YouTube channel of EFNNMA. So thank you very much and have a nice afternoon or evening or day wherever you are. Bye-bye. So how to